excellent teacher, and many people have learned quite a bit from her. She is a dedicated academician, clinician, mother, and sought out by many people. So we are very pleased to have her here, and I am glad to introduce her.
Thank you very much. Good morning. So I have been told that I'm restricted to the microphone, which is actually going to cramp my style, but I'll need to work with it. I want everybody to be able to hear, and this is being recorded. So I got this invitation to come from Dr. Lambiase because we spoke together at the Family Medicine Update in June, and he spoke right after me. And he actually came into the room when I was talking about vibrator use and made some kind of pithy comments, and here I am. So we're going to be talking about female sexual dysfunction because that's the world in which my professional efforts are focused. So I have no financial interest. And I will be talking about some non-FDA approved therapies, but I will mention it at the time. So our goals today are just explaining a framework for understanding normal sexual function, understanding different types of sexual dysfunction, and getting an overview of the outlines of what you should do in the office when you face a patient with sexual concerns. So Mary is a 32-year-old who you've done a routine exam on. She's healthy, takes no medications, and has a BMI of 24, which might mean that she doesn't live in the Hamilton County area. But as you wrap up the visit, she asks if she has, you ask her if she has anything she'd like to discuss, and she says, I've had no interest in sex for months, and I think it's just stress. So when we talk about the scope of the problem of sexual dysfunction, 94% of people report that sexual enjoyment is very important to their quality of life. And so as clinicians, if we are going to deal with something that 94% of people say is important, then we need to know and be able to have a mindset of dealing with this. About 40% of women have some sort of sexual concerns, and 12% of them report that it's distressing to them. There's a markedly high rate of sexual dysfunction in women of menopausal age, and we'll discuss possible reasons for that later. When I was a medical student at the University of Kentucky in 1985, I well remember a famed urologist coming to the podium and just putting his hands on the side of the podium, and he just leaned into the microphone and said, sex is 10% of a marriage when it's going well, but 90% when it's not. And I've never forgotten that. And after 30 years, I still think that that's really true. So our basic clinical concepts when we think about sexual counseling and dealing with patients is to understand the time course. Is it lifelong or acquired? Is it situational or generalized? And that all sexual behavior has biologic, psychological, interpersonal, and cultural contributions. And it's important for us to know that many patients consider just discussing their sexual concerns with a provider to be therapeutic. So while we think we might not have much to offer, that's not the case. So I did my residency at Washington University in St. Louis, where Masters and Johnson had done their research. And as you note at the bottom of this slide, they came to our departmental Christmas party every year, so I was able to have some very interesting conversations with them. The way that they studied sexuality, they saw it in a linear response of excitement, plateau, and then orgasm, and then some women especially are able to have multiple orgasms, and then resolutions. Since that time in the mid-60s, another model has been proposed, and that is a circular model of female sexual response. This actually encompasses what we know more about many factors and how it's not a linear response, but many things affect how women respond sexually. And it is a cyclical, it's a cyclical situation so that you can see if emotional and physical satisfaction is not going well, there's no emotional intimacy, you can kind of understand how it might wind down into sexual dysfunction. And the same thing is, if things are going well, it just goes in a circular fashion and improves. And down here you see the biological and psychological factors play into the whole circular response. When we talk about biology, it can be physical health, neurobiology, the way people are just wired, or endocrine function, and sociocultural, what kind of upbringing and cultural norms, and what kind of expectations were brought into the relationship. Performance anxiety and depression can be psychological aspects, and then interpersonal. What's the quality of current relationships? How have past relationships, abuse or good relationships, affected current situations? How long people have been abstinent, and what various life stressors are currently involved. So the DSM-5 has actually 5 categories. I've listed 4 because the 5th category is called other. But the first is lack of sexual desire, and then impaired arousal, inability to achieve orgasm, and then pain with sexual activity. So if you get a framework in your mind that there are 4 basic categories, that's somewhat helpful, but then they tend to overlap. By definition, the symptoms need to be persistent for 6 months and cause distress. Also, the symptoms need to not be better explained by a non-sexual mental disorder, severe relationship stress like violence, or other significant stressors. In a woman who has little spontaneous desire but has responsive desire in a relationship, that is not considered dysfunction. A desire discrepancy between partners is not considered dysfunction, nor is the reduced physiologic and sexual arousal related to menopause, which we'll discuss later. So overall, we can see that while there's greater prevalence of up to 40% of sexual complaints, the pink here is the actual distress, and that's much lower. And it has to be categorized as distress to be labeled as an actual dysfunction. So we talked about relationship factors, and there's been quite a bit of research going that proves or points to how relationship factors are really central in sexual satisfaction. So general emotional well-being and relationship with a partner have been noted to be the best predictors of sexual health. Low sexual desire with distress is associated with emotional and psychological distress and partner dissatisfaction. And then in menopause, sexual response and feelings for the partner have been noted as more important than hormonal status. So the take-home message here is that relationships are key. So what's our role as physicians and providers? Often we fail to ask questions about sexual health, though it's a clear area of patient concern. So it may be that we are actually embarrassed, or we feel time constraints, or we're to be concerned that it's not reimbursable. The majority of patients seeking physician help for decreased libido received no treatment, no intervention at all. The first step in evaluating someone is actually taking a sexual history. So how do you do that? This has been very interesting for me to watch evolve over the 3 decades of my practice, because we were trained in medical school to be very oblique about it and be very respectful and allow patients to bring the topic forward. And during that time, the whole cultural approach to sexuality has become so kind of out there that I hear medical students all the time, do you have sex with males, females, both? How often do you have sex? And they're very forthright about it. And I think for the younger patient, that's probably fine. I would argue that for the older patient, more nuanced, especially the older female, a more nuanced approach is in order. Good questions to ask are opening the door for patients by saying something like sexual problems are common. Do you have concerns? Or that if a patient is menopausal, say many women notice after menopause their sexual life changes. Some notice vaginal dryness and pain. Is this happening to you? And that Many women struggling with their weight have sexual problems. Is this a problem for you? So this approach allows patients to share as much as they want to without concern for embarrassment. So a full sexual status examination would be a comprehensive interview talking about current functioning, expectations, attitudes towards sex, the state of the current relationship. And there are many validated tools for this. They all take some time to administer. And then a careful physical exam of the vulva and pelvic floor muscles is very important. Involving a partner is useful and helpful when it's possible. There is a two-part sexual symptom checklist for women that starts with, are you satisfied with your sexual function? And if they say yes, then you're kind of done. If they say no, then you ask about time course and then have them mark what their problem is, trying to get at a diagnosis and which problem is most bothersome and do they want to talk about it. And this can be administered at the time of a routine exam. There's also a decreased sexual desire screener that gets at the patient helping you figure the etiology of why they might have decreased desire and getting to what their symptoms or what they think the root of the problem is. I find it very helpful to ask patients what they think is going on. This is also a couples problem. So if a partner ejaculates prematurely, the women may think, why can't he control himself? Why does he let me down every time? And these are often thought of but not spoken of, and just walls build up against communication and intimacy with the couple. The same is true with erectile dysfunction. Women often think, well, am I not attractive enough, or assume that somebody must have another partner. While this talk is on female sexual dysfunction, I'd like to just briefly mention that male sexual dysfunction can be categorized really into 5 different components of medicine side effects, vascular problems, such as hypertension and diabetes, hormonal problems, neurologic problems, and relationship and psychiatric. So you see these are very similar to problems that cause dysfunction in women. Poor general health typically affects sexuality, and all problems related to heart disease, vascular disease, any kinds of pelvic floor dysfunction, pain, trauma like motor vehicle accident with a broken pelvis or broken tailbone during a traumatic delivery, lower urinary tract disease such as incontinence, depression and anxiety, all of them really affect sexual health. So when we face patients with these diseases and these diagnoses, which we basically do every day, we need to realize that sexual dysfunction is an unrecognized and untreated aspect of their care typically. Disability. So either lifelong or acquired disabilities can profoundly impact sexual expression. Sexual adaptation is possible, and this is something that we can actually greatly relieve our patients with who've had strokes or have had other problems by just bringing this to the table and connecting patients to resources. So a study that came out this year showed that there's an improvement in sexual function after incontinence surgery. The conclusions were that it seems to be less shame and fear when symptoms improve. Incontinence during intercourse is a challenging problem for clinicians to deal with, and patients often do not want to talk about it. Pelvic floor physical therapy may help, and counseling and education are needed to promote adaptation. In my practice, if a patient says that she leaks urine, I try to talk to her about the fact that urine is sterile. It's not really a problem. It's like a normal biologic. It doesn't have to be a problem. It's a normal biologic fluid, and I think that resets their mindset. So obesity really affects sexuality. We know that 30% of adults are currently obese, and the predictions are it'll be up to 42%. So there is a study that shows the higher the BMI, the lower the female sexual function index score is in women. And sexuality is linked to body image and self-esteem, both of which are worsened with obesity. Bariatric surgery improves sexual satisfaction. So that's another thing we can talk to our patients about when we help get them ready for bariatric surgery. So William Shakespeare noted that alcohol provokes the desire but takes away the performance. And so the connection between alcohol abuse and sexual dysfunction has been known for centuries. Cocaine, methadone, heroin, marijuana have all been implicated in decreased sexual performance. Medications. I suspect that you all are familiar with antidepressants, anti-epileptics, this whole range of medications affecting sexual dysfunction. At the bottom I put oral contraceptive pills. It's been a question of whether they do or whether they don't. Some studies have shown that they do, some have shown that they don't. If a patient presents with usually it's decreased desire and has been on oral contraceptives, we typically offer them a pill holiday and try a different contraceptive for about 3 months and see if that changes their sexual desire. But remember, since sexual function is so complicated, so circular, and so overlapping, sometimes it doesn't have a straightforward answer. So SSRIs and sexual function are known to decrease libido in men and women, cause anorgasmia in women, increase ejaculation latency in men. And note, 30 to 70% of users, depending on the study, are involved. With fluoxetine, it seems to be about 50%. So anytime we start someone on SSRI, we actually should counsel them that this is a situation that can occur, that sexual function can be involved. So what should you do if somebody on an SSRI has decreased sexual dysfunction? You can decrease the dose, switch to another SSRI, or add bupropion or Wellbutrin, 150 milligrams BID. That's been shown to improve sexual functioning in women on SSRIs. You can switch to another type of medication or offer a drug holiday. For many of our patients on SSRIs, this is a complicated situation to deal with because their depression can be lifted, which helps their overall life, but then they develop a new problem of sexual dysfunction. Another category of people who are involved with who often have sexual dysfunction are survivors of childhood sexual abuse. And anytime we see a female in the office, we need to acknowledge that 20% of the time this woman will have been abused as a child. There are emotional reactions of guilt, fear, self-blame, and often depression and anxiety. So they have many of the same symptoms of post-traumatic stress. In our clinic, we're very used to seeing patients who come just for a routine exam, and we realize that we are unable to perform the pap smear without them just wincing, pulling back, whimpering, and a lot of times that's because they have been sexually abused. Destructive relationships are often result from childhood sexual abuse. And their sexual activity as adults is often associated with, or in their mind they feel a sense of violation and pain. So it causes all manner of sexual dysfunction. Notice that this is from American College of OBGYN committee opinion. This is a problem that is so recognized in our literature that it is front and center. So how do we approach survivors of sexual trauma? First, realize the vulnerability and fear, and then normalize the experience. Just say, about 1 in 5 women was sexually abused as a child. These experiences affect health. I ask all my patients about this, and that gives them the ability to come forward with their story. And then just letting them know that they are not to blame and appreciating the courage that it took for them to talk to you. In patients with these backgrounds, early referral for counseling is really key. So what about sexual function in pregnancy? The first trimester is often associated with fatigue, emotional changes, nausea, breast tenderness, and fears about miscarriage. So a lot of women report that their sexual satisfaction is not as high in the first trimester. Now, second trimester, often women feel more erotic and energetic. Vaginal lubrication increases with increased blood flow. Some women report reaching orgasm for the first time in the second trimester of pregnancy. And that orgasm is is easier than it was before they were pregnant. With the third trimester, just aches and pains of pregnancy often come forward, and just the positioning for intercourse can become very difficult for women, and they report less frequent intercourse. In breastfeeding, with a progesterone-dominated stage, there's decreased lubrication and often less sleep. So we're going to move now to talk about specific treatments for specific sexual dysfunctions. So for hypoactive sexual desire disorder or disorders of desire, testosterone therapy, and then other medications we'll discuss. What to do with orgasmic disorder, and then how to handle pain and the genitourinary symptom of syndrome of menopause, which is the new name for atrophic vaginitis. So for decreased desire, it's typically studied using SSEs, which is satisfying sexual endpoint, or sexual events as the endpoint. Multiple patient inventory scales, which are expansions of the brief scales that I showed you earlier, and there are other inventories for when this disorder is actually studied. Cognitive and behavioral counseling helps with treating low sexual desire. And then of the medications, we'll talk about testosterone, flibanserin, and bremelanotide, which is brand new. Couples therapy can help. And then something as basic as improving general health, sleep, exercise, and less stress. And so that is something that residents may note affects their personal lives. So improving general health for all of us can improve our sexual functioning. So when we talk about testosterone therapy for women, the first thing to say loudly and clearly is that none are approved by the FDA for treating hypoactive sexual desire disorder. There is a esterified estrogen and methyl testosterone known as Estertest. It has been on the market for decades and decades and decades. And it has typically been used as an oral supplement for women post-oophorectomy. And it is still available. It is not the, quote, cleanest estrogen or the cleanest progesterone as far as lipid side effects and blood clots. And so we tend to not use this very much. It does have the benefit that it is not expensive. Compounded testosterone cream is usually 0.5 milligrams per day, can be very helpful. It's not FDA approved. It tends to be $30 to $40 a month, and some patients find it helpful. When we study testosterone therapy and decreased libido, it does seem to help. It does not help all women, and it does not help all women for all time. We also have to be very careful knowing that we can induce hirsutism, acne, and then they can induce voice changes and frank virilization if you're not careful. So there is a patch, a testosterone patch for women that is used. It's on the market in Europe, and there are injectable and implantable testosterones that are used for women, and those can typically be obtained through reproductive endocrinology practices and other elite just practices devoted to hormone therapy. There's no proven efficacy for DHEA use, although that is available. It's important for us to know that endogenous levels of testosterone in women do not predict sexual function. If you have a menopausal age woman, there's no point in checking her testosterone to see about adding testosterone because there just isn't a correlation. Sometimes we do check testosterone levels in women that we are giving testosterone to kind of comfort ourselves that the level is not too high. But basically, we need to just watch the patient and see the symptomatology that she's experiencing. There are some studies showing increasing the androgen level up to the upper limit of normal female can help sexual function. And that testosterone patch is available in Europe has been shown to improve sexual function. But it is, again, not FDA approved. So testosterone is metabolized to estrogen. So you always need to ask if you have a patient on testosterone and they have a uterus, if they're having uterine bleeding. And the connection between exogenous testosterone administration in women and elevated breast cancer is not a clear connection. All right, so orgasmic disorder. Patient education is very key. A lot of women do not understand what orgasm really is. They don't understand that often it takes a lot of time for women to learn to, quote, become orgasmic, and that that's typical, it's normal, it's common, and that sexual skills training, which focus on directed masturbation and vibrator use, can help women. And then sensate focus, which is a technique that helps partners to communicate and to focus on to defocus on the active intercourse, but focus on improving their general sexual communication and the sensory aspect, and then it, over time, helps them with their actual orgasm function. Cognitive behavior therapy can help. And then there is a book that has been quite useful to a lot of women called Becoming Orgasmic. It takes them on a kind of inner journey and helps them to treat themselves. So phosphodiesterase inhibitors effectively treat male erectile dysfunction, but have not generally been proven successful for women, and they are certainly not FDA approved. So already in 2002 by Dassow et al., a study that's often quoted, it showed that sildenafil was no more effective than placebo. There is an exception, and that's women with SSRI-associated sexual dysfunction might be helped by it. It can be effective in women with diabetes, multiple sclerosis, and spinal cord injuries. So that's something just to keep in mind that you might want to try. How about herbal supplements? There's a lot of advertising going toward herbal supplements saying that they work well, but there's sparse data, and despite all the claims and the cost, nothing has been proven. There's minimal regulatory oversight, and we know that in medications that affect emotional outcomes and complex outcomes often have a 30% placebo rate. There's an herbal massage oil called Zestra that has shown in a small study to be of help, but that's something that patients can explore, but minimal data. Other pharmacotherapies. SSRIs for premature ejaculation in men can help sexual function in women, because if you help both partners, it can help the whole situation. So buspirone, in some studies, shows improved sexual functioning. It's not across the board. It's not FDA approved. Now, bupropion, in a randomized trial of 75 premenopausal women with decreased desire disorder without depression, reported increased sexual functioning. So it's something that may be worth a try. There's some newer pharmacotherapies. One is flibanserin, called ADI, which is a 5-HT1A antagonist. It's interesting because it comes with a lot of strings attached. It only increased the satisfying sexual events about once a month, and so a patient has to know that. Alcohol can't be used during therapy because it can result in severe hypotension or syncope. And the FDA has considered this to be of enough concern that physicians have to get certified and use special contracting with patients to try this. It is also $400 a month to use. So in my mind, this is not something I've ever prescribed for a patient, and at this point, I doubt that I ever will. So bremelanotide, Vyleesi, was just approved last month, and it will likely be on the market by September. It's a melanocortin agonist. It's injectable, and it's expensive, we know, but the price is not yet set. It is also for premenopausal women, and so just keep your ears open for that. But again, there are many reasons for us to think that's not going to be a panacea. So devices, sexual devices, can often be helpful with orgasmic dysfunction and partner erectile dysfunction, and in patients with motor and sensory dysfunction from problems such as MS or diabetes. Over-the-counter, widely available at stores and online. They typically cost only $30 to $40, and there are many types and sizes available. I try to talk to patients, giving them permission to use them, because a lot of, especially the older patient sets, they tend to have emotional reasons and embarrassment reasons that they would not want to try these devices. But hot off the press, in the June 2019 journal, our Green Journal, the Journal of Obstetrics and Gynecology, which is one of the lead journals in OBGYN, it's a clinical reference guide on sexual devices for the obstetrician gynecologist. It's a very clear article that I would turn your attention to if you're interested in this. Now, female sexual pain. By definition, it's vulvo-vaginal or pelvic pain that's provoked by or exacerbated during sexual contact. The etiologies can be myofascial pain syndrome, infections, hormonal changes, trauma, neurologic, post-surgical, psychological, and relationship factors. So we're back to the same multifactorial cause that makes you think that female sexual dysfunction is kind of like a dance. And the same thing with pain. It's often very hard for us to tell the etiology of pain. And in a lot of patients, what we conclude is it has multiple different etiologies, and the goal is to try to treat as many as we can. Very common causes of female sexual pain are menopausal atrophy, lichen sclerosis, candidiasis, interstitial cystitis, and endometriosis. Each of those topics could deserve a lecture on their own, but obviously you would not be able to diagnose atrophy, lichen sclerosis, candidiasis without a careful physical exam. I would say the same about the other two. So physical exam of the pelvic area is very key. And then also just talking about the connection between sexual pain and prior negative sexual experiences. So we want to treat the underlying cause. If it's vaginismus, which is involuntary muscle contractions upon vaginal penetration, it can be very successfully treated, over 70% success rate. Botox can be used prior to starting self-dilation, and that is, we have not used that here in our clinic, but some clinics are using that. I've had multiple patients over my years practicing who confessed to me that they had unconsummated marriages. And on physical exam, it was basically impossible to put a speculum in, and it was because of contractions. And it would seem like those would be impossible or very difficult patients to treat, but it's not true. They need to be given permission to get dilators, and I talk to them about a source. If I sense an embarrassment on their part, I actually show them online how to get medical dilators and talk to them about their use, just in the privacy of their bedroom with lubricants. You want to treat candidiasis and lichen sclerosis. Over time, if untreated, pain often causes decreased libido, and a cycle develops with sex hurts, and so your women become less interested, and then because they're less interested, they don't have it, and because they don't have it, their tissues get tighter, and then it becomes more painful when they do. And we want to try to break that cycle. So pelvic floor physiotherapy. This is a remarkable field. And there are many practitioners here in Chattanooga who do a marvelous job with this. You can let your patients know, if you refer them, for pelvic floor physical therapy, that this will all be done in a very private room, and it will be done by a practitioner who is very calm, has time, and talks to them and believes in patient education. We've seen many of our patients improve remarkably with pelvic floor physiotherapy. You can go into Epic and do referral physical therapy and just put in the details pelvic floor. And in our case, Benchmark will actually assign the patient to somebody who specializes in pelvic floor PT. What can they do for us, for our patients? They can do soft tissue mobilization of the perineum, vagina, and rectum. They can do myofascial release, where muscles and their fascial connections have just become tight over time. They can do trigger point pressure that causes myofascial release, visceral, urogenital, and joint manipulation that can help electrical stimulation to improve the ability of the muscle to contract, therapeutic exercises, active pelvic floor retraining, so they can help the patient become an ally in retraining her pelvic floor. Biofeedback is also used, and then vaginal dilation training. So if you start a patient with vaginismus you suggest dilators, that's a patient who I would have very low threshold to go ahead and send to pelvic floor physical therapy. What about estrogens? This has been a real hot topic in OBGYN for decades. The Women's Health Initiative study, the original part of that was published in 2002, July of 2002, in fact, and that has had many different arms that have come out over the years, but they found that systemic estrogen therapy did not improve sexual satisfaction. It's been very interesting because I think many of us who practice OBGYN and have seen a wealth of patients placed on menopausal hormone therapy, many of them report improved sexual functioning. So it can be difficult to actually document, or it was in the Women's Health study, but we often find a different picture. So women with vasomotor problems such as night sweats and sleep disruption, which are directly related to estrogen deprivation, and they're started on hormone therapy, their sexual problems may improve just by treating those symptoms. We do know that estrogens help treat pain from the genital urinary syndrome of menopause. So GSM, the old name was vulvovaginal atrophy. So what we see in this this diagram is that this is the introitus of a menopausal woman. And you see that there's a general flattening of the labia minor. There is the mucosa is generally flat, and it's also dry. There's no discharge here, and women often experience a burning sensation and pain, often with introital dyspareunia at the beginning of penetration, but often they experience deep dyspareunia also. Unlike vasomotor symptoms, which 70% of women have during the menopausal transition, most of the vasomotor symptoms will peter out over time. That's not true about GSM. The atrophy actually increases and the symptoms worsen. 28% of patients do not tell their partners that this is a problem for them during menopause, but they tend instead to avoid intimacy. So this is something that's straightforward to treat and can make a very big difference in the patient's life. So a double-blinded study showed that of 285 women showed that low-dose vaginal estrogen cream significantly decreased dyspareunia, or painful intercourse, and increased sexual interest, orgasmic response, and relational satisfaction. So instead of just the pain, there is proof that the whole sexual response is improved by local estrogen. Topical lubricants may help. Topical or systemic estrogen can be considered even in cancer patients. The reason I bring this up is that many of our patients who've had cancer, their cancer diagnoses seem so overwhelming that they often diminish the importance of their sexual function. in a clinical setting, but if you really talk to them and talk to their partners, it's a huge issue. Some patients have such dryness after menopause and breast cancer that they would actually be tearing. Their perineum sometimes bleeds even with wiping in after urination. And so it's a substantial issue. There is very limited information on topical estrogens provoking cancer. And in fact, there's a lot of evidence that they have limited absorption and that they do not cause any systemic problems. So if you have such a patient, I'm going to work with your oncologist to formulate a plan. There's also an option with a SERM of ospemifene, which is called Osfema, and it can improve the vaginal lubrication. It's an estrogen agonist in the vagina. It may cause hot flashes. It's expensive. The GoodRx price is $220 a month, but for some patients it can be just a big help. When we talk about using topical estrogens, topical vaginal estrogens, a little tablet here called Vagifem, it's also called Uvafem. It's 10 micrograms. It comes in an inserter here with a little tablet at the end. The patient merely puts this in her vagina and pushes a little knob at the end, and the tablet is released into her vagina. It's clean, and patients tolerate it very well. It's $63 a month. The reason I'm telling you the prices is because insurance has been very, very slow to pay for estrogens, topical estrogens especially. And estering can be a wonderful thing. I was unable to get a clearer image, but this is a very small ring that is placed in the vagina. It's good for 90 days. The patient simply leaves it there. But notice that the price is $439. So for many of our patients, that's quite prohibitive. Estrogen creams, at the top is Premarin cream, which is conjugated equine estrogens. It used to be very, very cheap. It's been on the market about 80 years. But notice the GoodRx price is $367. Estradiol vaginal cream, the brand name is Estrace. That can be had for about $96. And that's considered a month supply. Patients often use less than that with still good results. Compounded topical or compounded vaginal estrogen can be available for about $40 a month. If you've never used compounded estrogen before for atrophic symptoms, I would recommend that you simply call a compounding pharmacist and talk to them. And they will talk to you about the formulations they can make, and then you can let your patient know. What about systemic menopausal therapy? It's also very effective for GSM. Obvious caution if a history of DVTs, MIs, any kind of cardiovascular events. But the dose is much lower than oral contraceptive agents, so the contraindications are actually different than those for oral contraceptives. For instance, smoking is not a contraindication for hormone replacement therapy. And that is a whole nother lecture of estrogen use in cardiovascular events and breast cancer. It's a very, very interesting topic, and the pendulum is swinging now toward higher, more frequent use in more of our patients. So transdermal estradiol patches, they are systemic, but they do not increase VTE risk. It's very important. So for us, when we're starting patients on hormone therapy, our gold standard is a transdermal patch with a bioidentical progesterone, which is called prometrium. If the uterus is present, progesterone or a progestin must be given to prevent endometrial overgrowth. All right, have any of you all heard of Mona Lisa Touch and vaginal rejuvenation? Highly advertised. And it basically is a vaginal carbon dioxide fractional laser therapy. It is not FDA approved. And in fact, the FDA recently censured several of the companies for, quote, deceptive marketing. This is one of the things that the studies are limited, but patients often report that they really have good results from it. It's very hard to know. I mean, I personally have not ever referred a patient for this. There are some practices in town who use it. The price is high, and complications such as bleeding, scarring, stricturing have certainly been reported. So our conclusions. So biopsychosocial management includes a medical provider, pelvic floor physiotherapist, a sex therapist, which we'll talk about how to get a sex therapist in a minute, and then this whole model of biopsychosocial management has been proven to show patient perceived benefit and satisfaction and value. A mindset to go forward with this and a model approach to sexual problems was developed actually in the 70s. It's PLICIT, and it's a basic framework for us to think. The first thing is permission, which would be asking questions and dealing with the history, giving the patient a way to express their concerns. And then limited information. It's limited because we only have a certain amount of time in the office, and it's regarding the patient's, so limited information about their concerns, dispelling the myths. And then you may want to give limited information, give some reading material or some resources, and then have the patient follow up. And specific suggestions. And then intensive therapy, so that would need formal training and a referral. So recognizing the magnitude of sexual concerns for patients, include sexual health evaluation and routine care, take more complete histories, and develop your personal approach. And then I put on here, first, do no harm, because I think that should wind through everything that we do for patients. The ways that I think we can do harm in dealing with sexuality in the office with patients is to imply that something is wrong with them, or to invalidate their concerns, or to act like it's no big deal, or to act like they're the only one with this problem, or to be surprised because you've never heard of that before. So if we go back to Mary from the beginning of the lecture, she stated she had decreased libido. So we're going to take the history, and we talked about the tools that are available. And you're going to see Mary's context and actually ask her what her goals are. Do a brief intervention with readings, schedule a follow-up, and decide her level of care and her need for referral. So I'm a big believer in suggesting reading resources for patients because it allows them to evaluate themselves and to see themselves in the broader context and their concerns. And then education is really important in moving forward to therapy because they'll know what their options are. I would recommend, before you give any patient a source, that you're familiar with it yourself, because you may be very surprised at what you're giving out. And different patients have different comfort zones. Couple reading together can actually greatly foster their sexual communication, and we established pretty clearly that relationship issues are a lot of the problem. Here's some books that I use: Sheet Music, My Secret Garden, Secrets of the Sexually Satisfied Woman, Getting the Sex You Want. You can tell that these come from different perspectives. Becoming Orgasmic, For Women Only, and Intimate Issues. So in fostering intimacy, sexual communication and intimacy take dedicated time. So we live in the generation of Facebook media, rushing around, kids at events every night, and often patients will acknowledge that they don't spend much time together. When the time that couples spend together is studied, it's often like 5 to 7 minutes a day in communication with each other. So protected time away from everything that distracts can have a great impact on women's sexual lives. And that the context for sexual expression really has to be created. So rushing, lack of privacy, no foreplay, they really inhibit female sexual response. Then we talked before about lubrication for sex for women. Olive oil, coconut oil work. They're inexpensive. You have to be careful with condom use with those, but they can also stain your sheets. But many, especially women in settled relationships who are older, find those very helpful. A modestly full bladder can make orgasm easier for women. And when I say modestly full, it would just be not void right before beginning the sexual encounter. And then when to refer. So if your discomfort or inability to care for a patient is in the way, obviously they need referring. Long-standing relationship difficulties or psychiatric problems obviously need referring. If a patient doesn't improve or they want a referral, that's also key. I would highly suggest that you know the professionals to whom you refer and that you locate a physical therapist who treats pelvic floor disorders. It's very informative to me to go out and actually see a pelvic floor physical therapy setting and see where this was done. I also went and visited a sex therapist in town, and that made me, there were elements there that made me uncomfortable, and I don't know, it might make my patients uncomfortable. So you have to figure out what is going to work. There is an association, the American Association of Sex Educators, Counselors, and Therapists certifies people, and you can find by zip code where the therapists are in your area. And sex therapy can be very expensive, but for many patients it's quite a help. There's some other references, and then I can take questions. Yes. Yes. There is. It's not as pronounced, and I think the question is that vascular disease is a great contributor to male sexual dysfunction. And and the question was, is it the same in female sexual dysfunction? And the answer is yes. So diabetes and vascular disease can contribute to that. However, the ability for the female to experience vulvar and perineal engorgement is not often by the patients perceived as central. It's certainly not as central to sexual function as it is in males. And in women, it's a lot of times if diabetes is advanced and other problems are going on, they also have atrophy, which we can treat. And treating atrophy or the genital urinary syndrome of menopause by topical estrogen actually increases blood flow. So that's a study. Yeah, so the answer is yes, but not in as profound a way. Any other questions? So when I was a faculty member at the University of Kentucky, we were having a provider meeting, and all of us were sitting around the table talking about our well-woman exams or something. And somehow the topic of asking patients about their sexual function came up. And I was in a room with 7 providers in OBGYN, and I realized that I was the only one who asked that question regularly. So I feel like that's unfortunate, but I totally understand why that happens, because it's just, you're like, oh gosh, I thought we were done with this appointment, and I've got 4 other people in rooms. But I would just encourage you to figure out ways to just bring this into the warp and woof of your encounters with patients in a way that's natural and helpful for them. Thank you very much.